My name is Brandon Holland, and I'm excited to present my final project to our Patient-Oriented Outcomes course. Today's project will address the use of patient-related outcomes instruments in our practice. The clinical scenario includes a 16-year-old male cross-country athlete who presented with bilateral pain in the anterior medial sections of his lower legs. The athlete sought treatment after 5 weeks of persistent pain. The clinical impression of the athletic trainer is that the athlete is suffering from medial tibial stress syndrome. Here is a look at the athlete's condition as it is viewed through the International Classification of Functioning Disablement Model. The health condition is listed as medial tibial stress syndrome. Body functions and structures. There's decreased muscle output and endurance and increased muscle inflammation. Activities affected are running, jogging, and walking. Participation. The athlete is having difficulty navigating school, training for events, and competing and practicing with his teammates. Environmental factors. The athletic trainer advises the athlete and coaches on how to maximize performance during competition and minimize discomfort during all other times. Personal factors. The athlete has prior experience with medial tibial stress syndrome. The athlete is a 16-year-old high school junior and a two-sport athlete. When considering this patient through the construct of a health-related quality of life, it is important to note that the condition in the athlete's lower legs will affect him across multiple dimensions. Physically, the pain in the athlete's lower legs is affecting his ability to train. Because he cannot train regularly, his cardiovascular fitness and performance ability are both being diminished. Psychologically, the athlete is anxious and nervous about not being able to compete in the postseason regional and state events. Socially, the athlete is experiencing strained relationships with some of his teammates and coaches, as some believe that the athlete may not really be injured but simply does not want to compete or participate in the rigorous training of the team's activities. Economically, the athlete cannot afford new shoes with proper cushioning or proper inserts. Also, because the athlete's work boots affect his condition, he is unable to work at times, and this also adds to his economic hardship. This project will compare two patient-related outcomes instruments, the lower extremity functional scale and the foot and ankle ability measure. Both the lower extremity functional scale and the foot and ankle ability measure have been rated as excellent in reliability. Both are supported by the SF36 form as being valid. The minimum detectable change for the lower extremity functional scale and the foot and ankle ability measure are 9 and 12 respectively. Both patient-related outcomes instruments have a minimum clinically important difference of 9 points. For precision, the lower extremity functional scale has a margin of error of plus or minus 5.3 points. The foot and ankle ability measure actually has two subscales, one particular to athletes, which has a margin of error of 12.3 points plus or minus, and one for activities of daily living, which has a margin of error of plus or minus 5.7 points. It is important to note here that the sports subscale may make the foot and ankle ability measure more functional to our use as athletic trainers as we deal with athletes who participate in sports. As far as feasibility is concerned, both scales can be completed and scored in relatively short periods of time and with relative ease. So all things considered, both scales score very similarly across all ratings. So which patient-related outcomes instrument is best for my clinic in the secondary school setting? I chose the lower extremity functional scale. As mentioned before, both the LEFS and FAM have similar ratings in validity and acceptability. Lower extremity functional scale has slight advantage over the foot and ankle ability measure, and that is applicable to more regions of the lower body and not just specific to the foot and ankle. So how do you measure change in the athlete's health while using the lower extremity functional scale? The 95% confidence interval for the lower extremity functional scale is 5 points. This means that if an athlete takes a test repeatedly at one point in time, it is 95% likely that all of the scores will be within 5 points of each other. The minimum detectable change is 9 points. This means that the athlete's score must increase or decrease at least 9 points before the patient's health status could detect a change. The minimum clinically important difference is also 9 points. This means that test scores must increase or decrease at least 9 points before the difference in the results should be considered by the clinician as significant. So as we continue, if the patient's score goes up at least 9 points, the clinician can assume that the patient's health status is improving, and whatever interventions have been embarked on have a positive effect on the athlete's health. If the patient's score goes down at least 9 points, then the patient's health status is deteriorating. This means that the interventions are having a negative effect on the athlete's health. If the patient's score goes up or down less than 9 points, or if it stays the same, the patient's status has stabilized. Consideration will also be given to objective functional testing. So, with the use of strength, flexibility, and stability measures, in addition to the patient-reported status, we can determine if the athlete is improving or declining and when the athlete might be ready to return to activity. The next step is to incorporate the collection of patient-related outcomes instruments data in my clinical setting. I believe that I have come up with a very useful approach to collecting data. I have created an application that will allow athletes to submit patient-related outcomes instruments data at any time of the day from any place where they have a cellular connection or a wireless internet signal. If you would like to see a demo, please use your smartphone to text the word ATC to 55469, or open your phone's browser and go to the website that you see on the screen. It's important to note that the website is case sensitive. This uses the most popular form of technology for my population of athletes, teenagers, to facilitate near instant collection and scoring of PROs. It's widely available and can be done from virtually anywhere. And because it can be submitted before or after an athlete's visit to the training room, we can save time, and the time that is spent in the athletic training room can be dedicated to treating and getting athletes in and out as quickly as possible. The app can be saved to smartphones and tablets for one-touch access, and patients can receive reminders and additional info from the clinic. In my clinical setting, I would plan on collecting patient-related outcomes information from my athletes once a week, So the athletes will receive a weekly reminder to turn in their data. Here's some information on how the service works. The app service is provided by a company. The clinic orders the service from the app company. All data and subscribers to the app and messaging is managed by the clinic. The app company has the capability to access the data and the phone numbers of the subscribers, but will not do so except to help the clinic with technical difficulties. The app company agrees not to share or sell any info with any other party. The app company has no endorsements related to HIPAA or FERPA, but the app company's policies are compliant with the regulations of both privacy acts. I've identified some barriers to our implementation of using mobile apps to collect information. The first is patient compliance. The system will work best if patients use the app on a consistent basis. Patients may forget to submit their PRO instruments, as they forget many things. One solution to this would be to send weekly reminders to the patients through SMS text messaging to remind them to submit their PROs. A second barrier is the inability for some of our student athletes to access cellular data, or some of them have non-compatible phones. Athletes may run out of data at the end of their billing cycle, or they may have antiquated cellular devices that do not support mobile apps. A solution to this would be for the athletic training room to be outfitted with tablets that athletes can use during their visit to submit their PRO data. This is the conclusion of my presentation, and I would like to thank you for taking your time to look at and evaluate my presentation. I look forward to your feedback and constructive criticism as I prepare this idea to submit to my administrators to actually implement into my training room setting. Thanks again, and have a wonderful day.